There are several combination approaches being explored in JAK inhibitor naive patients. So, I will start off with Pelabresib. This is a bromodomain inhibitor from MorphoSys, and this drug really has caught everyone's attention because in the front line they showed a 68% spleen response and a 56% symptom response, which is unprecedented in combination with Ruxolitinib. For reference, Ruxolitinib by itself gives you about 42% for spleen and 46% for symptoms, which would tend to make you think that this is truly a synergistic combination, and it is backed up by some really solid lab studies showing the synergism in vitro and in vivo. And so that is where this drug is being developed, although it has other utilities. It has been studied in the add-on setting as a single agent, but from a regulatory standpoint, where the company is going with this is in the front line with Ruxolitinib. Then there is Navitoclax, which is has been around for a while, never really gotten approval for anything, but mechanistically a very interesting drug, BCL2 and BCL-XL inhibitor. We all know about the success of Venetoclax, which has been phenomenal. So Navitoclax is a sort of an older cousin of that, which inhibits both BCL2 and BCL-XL. So the apoptotic pathways, or rather promotes apoptosis is what I mean, by blocking the anti-apoptotic proteins. They too have some very nice results in the frontline and add-on settings. In fact, the spleen responses are close to those of Pelabresib and Ruxolitinib in the front line, something of the order of 63 or so percent. Symptoms a little bit lower, about 41% for the combo of Navitoclax and Ruxolitinib. We just heard those data at EHA. Smaller number of patients than with Pelabresib, but one concern with Navitoclax is that because of the way it works, it really drops the platelet count, and that can be a problem or a barrier in everyday clinical practice with the intensity of monitoring that's required and stuff like that. Now then, after those two, there's actually quite a few others at various stages. There's Parsaclisib from Incyte, which is a PI3 kinase delta inhibitor, and they're adding that to Ruxolitinib in two phase 3 studies, one in the frontline setting and one in the suboptimal setting. So they're doing that. The phase 2 data have been out there for some time. There's activity, but a little bit more modest than I would say Navitoclax or certainly Pelabresib, but that's something to watch as well. They have not seen the usual toxicity issues you encounter with PI3 kinase delta inhibitors. That's been extremely interesting. And then very early, but Selinexor caused a bit of a buzz at ASCO this year when they showed out of their first 8 patients, 6 patients achieving SVR 35 or a spleen volume reduction of 35% or more, which we abbreviate as SVR 35, in 6 out of their 8 patients at 12 weeks. Now, very early, who knows how much Ruxolitinib is doing, how much Selinexor is doing, but just something that caught people's attention. Again, I'm sure I'm missing other combos, but those are the first few that come to mind. And also, just to be complete, I will say that these are mechanistic combos that are intended to lead to synergism, but then you also have combos which are just logical because you want to improve blood counts with the other drug, which Ruxolitinib doesn't really do or actually worsens. So Luspatercept is being looked at in the Independence trial. It's a phase 3 trial against placebo, where it's being added to patients on Ruxolitinib who are requiring blood transfusions. So obviously that would be a very utilitarian combination if that were to get approved, because cytopenias are such a big struggle. So yeah, I'll stop there for now with the combos.